if you break your arm, an X-ray gives you a perfectly clean binary diagnosis. You see that jagged white line on the film, the doctor points to it, and you know exactly what's wrong.
Right. It's very straightforward.
Yeah, it's comforting, honestly. We like our medicine to be visible and, easily categorized. But the second a newborn takes its first breath, that diagnostic clarity completely vanishes.
Oh, absolutely. It's gone.
We step into the absolute definition of medical muddy waters.
I mean, the transition from the womb to the outside world it's the single most dangerous, chaotic, physiological event of a human's life.
It really is.
We often think of birth as a finish line, right?
Right.
But biologically speaking, it is very much a starting gun for a massive wave of environmental challenges.
Okay, let's unpack this because today we're doing a deep dive into a really expensive medical textbook excerpt on the clinical management of acquired problems in the newborn.
It's a dense text, but so fascinating.
It is. And whether you're a med student prepping for an exam, or you're staring at your own sleeping infant in a bassinet, or you're just intensely curious about human biology, our mission today is to explore a pretty incredible mystery.
Which is how the environment, right, the environment outside of our genetics.
Exactly. How that environment immediately threatens and ultimately shapes the very first days of human life.
Well, we have to start with the physical reality of the exit strategy. I mean, squeezing through the birth canal subjects the infant anatomy to immense mechanical pressure.
It's not a gentle process.
Not at all. A newborn skull isn't a solid helmet. It's a highly adaptable puzzle. The bones aren't fused, which allows them to overlap.
Right, the text calls that molding, right?
Yes, molding. It's designed to withstand that journey. But when that physical pressure exceeds what the puzzle can handle, we see structural failures.
And the text mentions depressed skull fractures, which it literally describes as ping pong fractures.
Which is such a vivid name for it.
It is. I'm picturing like a plastic ping pong ball that gets stepped on and just caves in on one side.
That is precisely what it looks like, yeah.
Yeah.
It typically occurs during a difficult vaginal birth from the sheer force of the fetal head pressing against the mother's bony pelvis.
Or from forceps, I imagine.
Exactly, or from the use of obstetrical forceps. But while bone fractures sound severe, the soft tissue injuries are often far more critical.
Wait, really? The soft tissue is worse than a fractured skull.
It can be. Anatomically, this is absolutely fascinating. There is a specific type of bleeding called a subgaleal hemorrhage. It bleeds into the subgaleal compartment of the scalp, which we classify in medicine as a potential space.
A potential space, meaning it's not a cavity until something forces it open.
Exactly. It's basically a hidden cavern in the anatomy. Under normal conditions, the tissue layers just rest flat against each other.
Right.
But if the vessels shear, that space can separate and expand exponentially. And because there is no bone to compress the bleeding, that hidden cavern can hold up to 240 milliliters of blood.
Okay, wait, I need to contextualize that. How much blood does a newborn actually have?
About 240 milliliters.
You're kidding.
No, a typical 3-kilogram newborn can literally bleed their entire blood volume into their own scalp.
That is a terrifying mechanical flaw. Just the idea that a space can open up and drain the entire system.
It's a massive emergency when it happens.
But as I was reading this section, I realized not all of these mechanical traumas are accidental. I want to push back a bit on the idea that this is always just the maternal anatomy versus the infant puzzle pieces.
I know where you're going with this.
Yeah, because in some of these scenarios, the doctors are deliberately inflicting the trauma.
They are. And it goes against every instinct we have about neonatal care, right?
Yeah.
But if we connect this to the bigger picture of a life-or-death emergency, it is a necessary triage.
Like with shoulder dystocia.
Yes. Take severe shoulder dystocia.
Okay.
The baby's head is delivered, but their shoulders are physically too wide and become wedged behind the mother's pelvic bone.
So the baby is basically stuck, half delivered, and their oxygen supply is compromised.
It creates an immediate risk of severe asphyxia. That's a total lack of oxygen to the brain that can cause permanent damage or even death within minutes.
So what does the doctor do?
To free the infant, the obstetrician will intentionally fracture the newborn's clavicle, their collarbone.
They just break it on purpose.
Yes. Snapping that bone instantly collapses the width of the shoulders, just enough to pull the infant free.
Wow. So you trade a broken bone for brain function.
Exactly. It's a split-second calculation.
But how do you even treat a broken collarbone on a baby that small? I mean, you can't exactly put them in a tiny upper body cast, right?
You don't have to, actually. The newborn skeletal system heals at a blistering pace.
Really? So what's the treatment?
The standard treatment is just teaching the parents to pin the baby's sleeve to the front of their shirt.
Like, just a safety pin.
Just a safety pin. It immobilizes the arm for about a week to 10 days while the bone callus forms, and the body just does the rest.
That's amazing. So physical size makes the birthing process a tight squeeze, sometimes requiring extreme measures. But what's fascinating is that a large baby isn't just a genetic roll of the dice.
Not at all.
Often, that bulk is a symptom of a metabolic crisis that was happening long before the contractions even started. I want to talk about how the mother's environment heavily dictates the infant's biology, specifically with maternal diabetes.
Right, because the environment of the womb is entirely dictated by the maternal bloodstream.
Right.
If a mother has elevated blood sugar, that excess glucose freely crosses the placenta and just floods the fetal system.
So here's where it gets really interesting. I was trying to visualize the mechanics of this, and it's like the fetal pancreas is a thermostat placed next to an open oven door.
Oh, I like that analogy.
Yeah, the mother's high blood sugar is the intense heat pouring out of the oven, and the fetal thermostat panics, right? It frantically blasts the air conditioning, which is the insulin, to cool the house down and process all that sugar.
That is a perfect physiological analogy, honestly. The fetus is swimming in glucose, so its pancreas hypertrophies.
Meaning it gets physically bigger?
Yes, it physically grows larger and becomes hyperactive, pumping out massive amounts of insulin to maintain equilibrium.
But then the baby is born, the umbilical cord is cut, the oven door is suddenly slammed shut.
And the maternal glucose supply abruptly vanishes. But the fetal pancreas, it doesn't immediately get the memo.
It keeps the air conditioning blasting.
Exactly. It continues to pump out huge amounts of insulin into a system that no longer has the sugar to support it.
Oh, wow.
This triggers a profound metabolic crash called neonatal hypoglycemia. Within the first 1 to 6 hours of life, the newborn's blood sugar plummets,
How low are we talking?
often hitting dangerous lows of 40 milligrams per deciliter or even less.
Which deprives the infant's brain of the primary fuel it needs to function.
Right. It's a neurological emergency.
But that constant blast of insulin before birth does something else, too. The text points out that insulin is actually the primary fetal growth hormone.
It is. It accelerates protein synthesis and forces the body to deposit excessive amounts of fat and glycogen.
So they just get huge.
Yes. This results in what we call macrosomia, or a large for gestational age infant. They have a very distinct physical presentation.
Like what? What do they look like?
A round, chubby body, a plethoric or highly flushed red face, and massive internal organs. The liver, the spleen, the heart, they all physically outgrow their normal parameters.
Except for the brain.
Right.
The text specifically notes the brain is the only organ that doesn't get supersized, which means you have this massive, metabolically demanding body being run by a normal-sized neurological control center.
Because the brain doesn't possess the same insulin receptors for growth, so it remains standard size.
That's wild.
But that massive body creates a devastating physiological ripple effect. The sheer amount of hyperactive tissue increases the newborn's basal metabolic rate.
So they're burning energy faster.
A higher engine idle speed means the body demands more oxygen to fuel its cells,
And if they can't get enough oxygen, they hit mild hypoxia.
which then triggers the kidneys to release a hormone that manufactures even more red blood cells to capture whatever oxygen is available.
It's just one thing after another.
It really is.
Yeah.
This creates a condition called polycythemia. The blood becomes overpopulated with red blood cells. It gets thick, viscous, sludgy, which impairs circulation through the tiny microvessels.
And eventually all those extra red blood cells reach the end of their lifespan and break down. Right.
Yes, and they break down quickly.
And I know from the text that when red blood cells die, they release a yellow pigment called bilirubin.
And the newborn liver is already immature. It's like a slow-moving processing plant.
So it just gets overwhelmed.
Completely. When you hit it with the massive bilirubin load from all those dying excess red blood cells, the liver simply backs up. The pigment spills out into the tissues, resulting in severe jaundice.
Wow.
It is a direct, unavoidable chain reaction that started with the mother's blood sugar months prior.
So the placenta acts as this vital conduit for nutrients, but it's essentially an open border.
It is.
I mean, it lets in the glucose, but it also lets in entirely different external threats. Because the second the amniotic sac ruptures, the infant is exposed to a terrifying microscopic world.
Oh, absolutely.
Let's talk about the newborn immune system, or rather, the severe lack of one.
If we connect this to the bigger picture of evolutionary biology, A newborn is essentially relying on borrowed armor.
Borrowed from the mom.
Right. During pregnancy, maternal antibodies, specifically immunoglobulin G or IgG, cross the placenta. This gives the infant a temporary shield against the pathogens the mother has previously encountered.
But it's a degrading shield. The text mentions this concept of a nadir.
A nadir is the absolute lowest point. The maternal Ig antibodies have a finite half-life. They slowly break down over time.
While the infant is trying to build its own.
Exactly. Meanwhile, the infant's own immune factory takes months to fully spin up and start producing its own antibodies.
So there's a gap.
A dangerous intersection, usually around 3 to 4 months of age, where the maternal shield has almost entirely faded, but the infant's own shield isn't ready yet.
Leaving them wide open to systemic infections, like sepsis.
Yes.
And this is where the diagnostic muddy waters get really deep. I mean, if an adult gets a severe infection, we spike a massive fever.
Right. Our bodies cook the infection.
But a newborn's internal thermostat doesn't work like ours. The text states that early signs of neonatal sepsis often present as hypothermia. They get abnormally cold, not hot.
Their regulatory systems simply aren't mature enough to mount a classic fever response. Instead, they lose heat.
That's so counterintuitive.
It is. They become lethargic. They might stop feeding, or their respiratory rate suddenly increases. The clues are incredibly faint.
You're really looking for a needle in a haystack.
You are looking for a whisper of a systemic collapse before it becomes a fatal roar.
And the pathogens causing these collapses are a true rogues gallery. I want to drill down into a few of the most surprising ones from the textbook, starting with syphilis.
Oh, syphilis is brutal in neonates.
The text mentions a symptom called snuffles, which honestly sounds like a harmless cartoon character, but the actual mechanism is terrifying.
Yeah, the name is deceptively cute. Syphilis is caused by a spirochete, a microscopic corkscrew-shaped bacterium that literally drills its way through tissues.
Drilling.
When it infects a neonate, it heavily targets the mucous membranes of the nasal cavity. It physically erodes the lining, causing severe chronic inflammation.
So they get a really bad runny nose.
But the resulting copious nasal discharge isn't just mucus. It is teeming with live spirochete bacteria, making the infant highly infectious to anyone handling them.
Wow. A literal biological hazard in the nursery.
Exactly.
Then there's toxoplasmosis, which is a protozoal infection. The transmission path alone is wild. It usually comes from the mother handling contaminated cat feces or eating undercooked meat.
And the parasite easily crosses the placenta. It has a devastating affinity for developing nervous tissue.
It targets the brain.
Yes, it creates a very specific tragic triad of clinical signs in the infant. First, it causes hydrocephalus, which is a massive accumulation of cerebrospinal fluid crushing the brain from the inside.
Oh my God.
Second, it causes chorioretinitis, severely inflaming the retina of the eye. And most alarmingly, it leads to cerebral calcifications.
Calcifications, like calcium deposits.
The parasite actually creates literal hardened calcium deposits deep within the infant's brain tissue.
It's turning soft tissue to stone. That's horrifying.
It's permanent damage.
And finally, cytomegalovirus, or CMV.
CMV is the most common congenital viral infection in the United States. And it's incredibly stealthy.
Because there aren't always symptoms, right?
Right. The vast majority of infected newborns show absolutely no symptoms at birth. But the virus slowly damages the intricate structures of the inner ear over months or years.
It's a slow burn.
Yes, and it becomes the leading non-genetic cause of sensorineural hearing loss in children. The developmental delays often aren't caught until the child fails to hit speech milestones.
It's just an absolute gauntlet. But, you know, microbes aren't the only things crossing that placental border.
No, they aren't.
The chemical environment the mother exposes herself to leaves an entirely different lasting physiological legacy for the developing fetus.
This is an area where we really have to separate the social complexities of addiction from the hard clinical mechanics of the neonatal body.
Definitely. I mean, the text covers a wide spectrum of perinatal substance exposure, from tobacco and alcohol to SSRI antidepressants. But the most intensely managed condition is neonatal abstinence syndrome, or NAS, which specifically deals with opioid exposure.
Right. Opioids readily cross the placenta, the fetal brain receptors bind to the drug, and the fetus becomes physically dependent in utero.
And then birth happens.
The moment the umbilical cord is clamped, that constant, steady supply of narcotics is instantly shut off.
So they go into withdrawal.
The infant's central nervous system goes into massive overdrive, resulting in severe hyperirritability.
I'm trying to picture this, because if an adult goes into opioid withdrawal, they sweat, they get agitated, they have muscle aches, but a newborn's nervous system is barely wired. Are they just seizing?
Seizures can happen in severe cases, yes, but the hallmark signs are a high-pitched, completely inconsolable cry, violent tremors, and exaggerated reflexes.
That sounds exhausting for the baby.
It is. Their gastrointestinal tract also goes into overdrive, causing severe vomiting and diarrhea. The baby is trapped in a constant, agonizing state of hyperarousal.
Now, cocaine is also heavily featured in the text, and I've always wondered about the mechanics there. Is it the same kind of crash? Does a cocaine-exposed baby go through a similar withdrawal process?
This is a crucial physiological distinction, actually. Cocaine-exposed neonates do not experience withdrawal. They show signs of acute intoxication.
Wait, they're actively high after they are born?
Yes, until the drug completely clears their metabolic pathways.
How does that work?
Cocaine is a powerful vasoconstrictor. It rapidly and violently narrows the blood vessels. In utero, this restricts blood flow to the placenta, causing fetal hypoxemia, chronic oxygen starvation that stunts growth.
Right.
But after birth, the baby isn't going through withdrawal. They're essentially coming down from an intense stimulant high.
Oh, wow.
They are jittery, irritable, and hypertonic, but the neurological mechanism is entirely different from the receptor starvation of opioid withdrawal.
That completely shifts how you think about treating it. And speaking of treatment, I was really struck by this medical paradox regarding opioids.
The Narcan issue.
Yes. We all know naloxone, or Narcan, as the absolute miracle drug for adult opioid overdoses. First responders carry it everywhere.
It saves lives every day.
But the text explicitly states that Narcan is strictly contraindicated for infants born to opioid-addicted mothers. Why wouldn't you want to immediately flush the opioids out of their system?
Because the infant isn't overdosing.
Yeah.
They are dependent.
Oh.
Narcan works by aggressively stripping the opioids off the brain's receptors. If you administer that to a dependent newborn, you throw their fragile nervous system into an instant violent system shock.
So it makes it worse.
It triggers a massive withdrawal cascade that can cause immediate life-threatening seizures. The cure for the adult is basically physiological poison for the dependent newborn.
You have to land the plane slowly. You can't just rip the engines off.
Exactly.
So how do you treat them?
Well, for decades, the gold standard was the Finnegan scoring system.
What's that?
It's a highly complex, subjective checklist of 21 different symptoms. If the infant score got too high, doctors would administer small doses of morphine or methadone to ease the withdrawal symptoms.
Essentially weaning them off the drug over weeks in the NICU.
Exactly. But there is a profound paradigm shift happening right now called the Eat, Sleep, Console method, or ESC.
How does Eat, Sleep, Console change the process? It sounds a lot less clinical.
It throws out the 21-point checklist entirely. It focuses purely on the infant's basic human function.
Okay. Like what?
Can the baby eat? Can they sleep for an hour? Can they be consoled within 10 minutes of crying? If the answer is yes, you don't use medication.
Wow, really?
Yeah, ESC relies heavily on non-pharmacologic interventions as the primary treatment.
Like what, just swaddling?
Extremely tight swaddling with the legs flexed to contain the tremors. Keeping the hospital room incredibly dark and quiet to lower the sensory input.
Makes sense.
And most importantly, keeping the mother in the room to hold and soothe the baby continuously.
Does it work better?
The data is remarkable. By prioritizing these environmental comfort measures, hospitals are dramatically reducing the length of stay and significantly decreasing the need to ever expose the infant to morphine.
That's incredible. So what does this all mean for you listening? We started with the sheer mechanical force of birth, the overlapping skull bones and hidden caverns of blood.
Right.
We looked at how a mother's blood sugar forces a fetal pancreas to build a massive body that inevitably crashes. We traced how invisible pathogens bore through tissues to leave calcium deposits in the brain.
The toxoplasmosis.
Yeah, and how a chemical reliance dictates the very first sensations of the nervous system. The first days of life are just a staggering complex gauntlet.
They really are.
This knowledge fundamentally changes how you view a sleeping baby. I mean, they aren't just resting in a sterile bubble. They are actively, chemically, and physiologically fighting to adapt to a wildly chaotic world.
It is a monumental period of adaptation. And, the fact that the newborn immune system takes months to produce its own optimal levels of antibodies raises an important question for you to ponder.
Oh, what's that?
Well, in an era where human environments, from our homes to our hospitals, are becoming increasingly sterile and heavily managed, How might we be accidentally altering the evolutionary timeline of how a newborn's immune system learns to map and conquer the world around them?
That's a fascinating point. We want the clean x-ray. We want the binary diagnosis and the simple fix. But maybe those diagnostic muddy waters, the messy, chaotic interaction with the microbes and the environment, maybe those are exactly the crucible a newborn needs to actually survive in the long run.
It's definitely something to think about.
Absolutely. Thanks for diving in with us.